So at ASCO 2024, I presented updated data in cutaneous melanoma with the PRAME ImmTAC from Immuno-Oncology. It's now called brenetafusp. Brenetafusp is an ImmTAC, which is an immune-mobilizing T-cell receptor against cancer. On one side, it targets PRAME, which is a protein in cancer cells. It's expressed in 90% of cutaneous melanoma. On the other side, it targets CD3, so it brings T cells in. We're all familiar with ImmTACs because we have gone through the history of the GP100 ImmTAC, tebentafusp, which is approved for metastatic uveal melanoma as a first-line indication. With tebentafusp, we also showed that it could be easily combined with PD-L1, anti-CTLA-4, and tebentafusp PD-L1 anti-CTLA-4. This is an update from the Phase I/II study that looked at multiple solid tumors. The gating is HLA-A2 positive patients with cutaneous melanoma. At ESMO 2022, I showed some of the early data from Phase I, which showed benefits and responses in a multitude of solid tumors, including ovarian, lung, uveal melanoma, cutaneous melanoma, endometrial cancer. That was 7 cutaneous melanoma patients, and now we add to that, and we have 47 cutaneous melanoma patients treated in the first single agent portion of the study, escalation and expansion. We also present some of the early data in combination with PD-1 inhibitor pembrolizumab, and that's for safety and tolerability. So I'll talk about the single agent first. What did we see? Well tolerated, no new signals, no additive toxicity for continued dosing, very tolerable with grade 1 and 2 cytokine release syndrome, which was manageable and dissipated. We saw that the major grade 4 toxicity was lymphopenia, and that was because of the mechanism of action. This is taking those T cells into the tumor, and that resolved after dosing. So there was no grade 5 toxicity and only one person discontinued, so very tolerable. What about response? So we saw the greatest benefit in PRAME-positive tumors. That's 90% of cutaneous melanoma. We saw responses in heavily pretreated patients. These patients had all seen an anti-PD-1, with the majority seeing at least 2 regimens with anti-PD-1, with 80% having seen anti-CTLA-4, and 4/5 of those having seen CTLA-4 with PD-1 together. So an aggressive, heavily pretreated population where 38% had seen even another IO, whether it's LAG or some other actionable immuno-oncology therapy. And we saw responses in high tumor burden patients, BRAF mutated patients, patients with brain mets or liver mets or both. So this is a wide-ranging beneficial drug. What about response? Well, we saw the greatest benefit in our patients who had stable disease, minimal tumor reduction, and partial response. And this is an important thing here. So I'll take a moment and say, this is one of the most important things we've learned about this ImmTAC platform. That clinical benefit is not tied to just overall response. The clinical benefit is tied to stable disease, partial response, complete response. So the clinical benefit rate, anything like that. So for all comers, that was around 50%. The response rate was only 11%. And when we enriched for PRAME, those numbers went up. And we realized the patients who are doing the best have minimal tumor reduction to response. So when you look at the spider plots, these are patients who are getting a little bit of shrinkage, and it's ongoing for long durations. We had patients who were on for 22 months or more and continuing on study. We also saw that there were some people who had stable disease and went to partial response. Let me flip and talk about where we're heading with the drug in cutaneous melanoma. So we presented data with safety and 9 patients were treated, no new signals, very well tolerated. 1 patient had a DLT of a transaminitis who had transaminitis on checkpoint inhibitor before. And then another 12 patients that were on combination with other solid tumors showed the same tolerability. And that is lending us to a major randomized phase 3 study, PRISM-301, which is looking at brenetafusp plus nivolumab versus either nivolumab alone or nivolumab and relatlimab. And that is an ongoing phase 3 study now that's open worldwide. And from that, hopefully we can show that this drug, which is doing something that we've always wanted to do, bring T cells into tumor, not only is tolerable, but is efficacious and can be better than just treating with a PD-1 regimen alone. And why is that? Because we have a significant proportion of patients who are primary resistant to checkpoint inhibitor. And in this phase 1 study, we've seen that those patients can respond to even single agent brenetafusp. So let's see if we can do it for a greater population of patients.